What is an appointment in general practice? What does it actually mean to record, and how should you do that when it comes to tacking off things like the appointment data, AC008 if you're looking at from the IAF, and various other things when it comes to general practice? In this episode, myself and Andy are going to have a look at that and try and explain what on earth is an appointment and how you should be structuring your appointment books and various other things to comply with all the crazy guidance that exists out there. So let's tech enhance your primary care and learning. Hello, EGP learners, and welcome to this episode where we're having a look at some recent guidance that's come out, consolidated, shall we say, in terms of how to manage your appointment book in general practice, which may sound really dry and boring, but actually it's got some really significant ramifications, hasn't it, Andy?
Yeah, it is. Yeah. So interesting today to be looking at this consolidated guidance from NHS England, published on the 7th of November, 2023. Not quite sure when you're watching this, hopefully near to then, so it'll remain current for you. And I guess the NHS has been really interested, particularly in the last few years, in understanding the activity that actually happens in general practice. I think for a long time, the system didn't really have any idea, how much work and what types of work and appointments were happening in general practice. And, I think that was a bad thing, because I think probably there's a lot more activity that does go on and was going on than people may have thought. So in recent years, there's been a drive to categorize appointments in a way that is standardized across different GPs, different GP surgeries, and different parts of the country, so that we're kind of counting the same thing. We're comparing apples with apples, oranges with oranges in terms of the data. And it's really, really complicated, because I think people were recording their activity and putting their clinics on in all sorts of different ways. So actually getting a good data set that actually means something that you can compare over time and with different surgeries and parts of the country is really difficult. So there's been a drive to standardize the data. So people start talking about GPAD categories and so forth. So Gandhi, what's GPAD?
Yeah, so GPAD stands for General Practice Appointment Data, and it's based off the appointment books in general practice surgeries and stuff. So those of you working in primary care will absolutely know what this looks like, because this is where you look for your appointment slots and stuff, whether that's on EMIS, System 1 or any other kind of system and things. And basically they use an accountancy process that comes in the background to tell what types of appointments they are, based on how the slot types have been allocated. Now, this is based off guidance that came out a couple of years ago, back in 2021. And at that time, it was part of the investment and impact fund to make sure that you had allocated each of those slots to the correct slot type at that time. And that then followed into last year's IAF to make sure you've done that and stuff. And then this year is where they've now started to utilize that data to try and then do other kind of things. Many people probably would have seen some of the outputs of this in the regular kind of updates around general practice delivered 29, 30, 32 million appointments this month, and that kind of stuff. And it also supports some of the data about how many vaccination-based appointments were done previously. Obviously, that's a much smaller number now compared to if we go back 2 years ago and things. But it's now being used to also then help verify and analyze the appointment and access agenda, particularly the capacity and access improvement work that many practices and networks are currently doing. And obviously, networks are now paid the recombined IAF funds as that payment every single month, and the potential 30% extra payment that's going to come for probably next year, based on whether or not they've achieved their capacity and access improvement plans, commonly now called CAPE plans. We love our acronyms, don't we, Andy?
Yeah. So I think it's interesting that this data is now being attached and linked to payments to general practice, because that wasn't the case at first. And at first it was just about understanding and reporting on activity. But I think many people, including ourselves, predicted that before too long, this would start to be linked to performance monitoring, management, and potentially payments. And I think we might see more of that in the future. So really understanding what's going on and getting this right is really important. I think people who are most interested in this are probably going to be the GP partners, practice managers, and then primary care network managers, primary care network CDs, and board members, because those are the organizations whose funding is now linked to this data. But that means that they'll be obviously leaning on their staff to make sure that data is recorded appropriately. So I've started to see pop-ups in some of the places that I work just to confirm the appointment types, as you're finishing the
Yep.
appointments. For example, if you do extended access appointments, then you get one of those in Nottingham. So people need to understand how important it is to fill those in and to do so accurately.
Interestingly, I think we'll see even more of this. So I'm aware that some of the online consultation providers now also have a selection menu that comes up after you have done, for example, online consultations to show the output of what those appointments have been for that similar accountancy process to try and analyze and support that kind of data. We'll come into why that kind of works and doesn't work in a second. But as Andy mentioned, this is definitely being used to support payments. The key one for this financial year as well is something called ACC08, which is part of the impact and investment funding. It's 71 IIF points, which if you have no elements of compounding factors and stuff, it's approximately £14,000 per network, which is a sum of money to be noted, shall we say, in terms of the grand scheme of budgets for primary care networks and that kind of thing. So it is something that people need to be aware of and pay attention. Probably worth we have a look at the document, isn't it, Andy?
Yeah, so a few things to look at. So let's bring the document itself onto the screen. So we're on NHS England's website, and you can look at all of their press releases and new documents. So we've shown you how to do that in the past, and keep an eye out for new releases. It's not particularly long, and I think it really is about consolidating guidance that has been out there for a while. We were having a look through and trying to work out if we could recognize anything as particularly new, and I'm not sure that we spotted anything particularly new, but it's certainly good to see this guidance brought together in quite sort of a concise form, really. And I think they really just wanted to drive a further increase in data quality, and the document's reminding us that it's linked to funding now, and that these are the mechanisms through which it is, as Gandhi says, enhanced the DES Impact and Investment Fund with ACC08. Is that the need to be seen with? Is that the 2-week one, Gandhi?
That is. So that's the need to be seen within 2 weeks of contact with the practice and stuff.
So it's being used for that purpose. It's just really reminds us of the categorization of the appointments. So this is important when the appointment rotas are being set up by the manager, just to make sure that you set them up appropriately, and they want good data quality. So important things are that if we're recording something as a certain type of appointment, that needs to be what's actually occurred, and that something else hasn't occurred, because we need accurate data so that people can get the payments and the funding into general practice right, and understand how much work is going on, essentially. So so they categorize the type of appointments. I don't know whether it's worth just defining what an appointment is, Gandhi, because for a long time, I guess that wasn't defined. And here it is. Just this document links back out to a PowerPoint slide from, I think, around sort of 2021, when they were beginning to start doing this data. But yeah, so it's important to know what an appointment is. Gandhi, what's an appointment in general practice?
So 3 parts to an appointment. You're going to find this 3 things to most things in a second. So all relevant staff it can be involved in this, and it does include the additional roles themselves as well are included in this. So it's an interaction with a member of staff, okay? And it talks about the types of members of staff on the second page, but we'll come to that in a second. It talks about the modes of consultation. So this is face-to-face, telephone, video, every kind of mode. And the modes are then broken down a little bit later on, and we'll come to that in a bit more detail. And then the settings. So this is what the settings are now. This part there probably has been a little bit more attention in terms of what this means. And again, when we get back to the main document, we'll focus on the settings. So those 3 things have to be considered in terms of what an actual appointment is. What I thought was more useful on this particular slide is something, and this is something that I think me and Andy haven't actually noticed before, is what it excludes. And I think this is really important for practice in particular to be noting, because this is not what they will be counting when it comes to an appointment. So there's 5 things, I think 6 things on there, isn't there, Andy? Yep. So number 1 is purely administrative interactions between the practice. So this is things like your practice manager meeting with staff, or a patient to complete a subject access request, and various things around that. So something that doesn't seem to include an element of clinical interaction and stuff, that won't count as an appointment. non-clinical triage or administrative signposting. So this is when you may get a request from a patient, for example, through your online consultation things, and you've signposted them to actually a different section for them to fill in a report, or maybe signposted them to a local service or something like that that's not involved in a clinical journey kind of thing. Online requests that do not result in interaction between the patient or the healthcare professional. For example, on automated online triage. So I guess this is the AI mechanisms that automatically do stuff in the background, which some providers give this, some don't. But basically where there's activity where it hasn't resulted in a clinical interaction in one of the 6 modes that we'll come to in a bit.
But obviously triage where a clinician is in the loop is fine. It's just those that are purely AI driven.
Yeah, I guess our interpretation of that is automated. So that could be either automated by the services or AI driven and that kind of stuff. Work undertaken by a healthcare professional that doesn't involve a patient contact. So I think this one's quite important. So MDT meetings, case conferences, palliative care reviews are some of the ones that's listed. But the big ones are things like letters, document management, and results processing and stuff. Prescriptions as well, processing those are not counted as appointment data. I think that for many people may be one of the key ones that is considered slightly different, because I think many would argue that's a clinical interaction. I guess the question is what happens if by doing that document you then contact the patient. I think by that nature, because you've now contacted the patient, that is an appointment. So maybe you need to consider how you document that. Any clinical administration activity, so that's things like training, supervision, etc. And then finally, interactions with PPG groups and stuff like that wouldn't count as an appointment, which we can understand that one, I think. However, if that ended up being a group consultation, may turn it on its head there.
So I mean, many of those seem reasonable, although some of them take quite a lot of time, like, writing referral letters and other letters. That's the only one really that I think represents a significant amount of work, which, whilst it might not be an appointment, I think ought to be counted somewhere, and I guess maybe it will in the future. But I guess the key thing here is it's about the relevant staff, the mode, and the setting, because that's really what they want coding, which is what this document is providing.
Sorry, Andy, before you switch off, can you just go back to it? And it would be worth us showing the list of the staff, which is on the next slide. So if you just scroll down, and there you go, you've got the list of staff basically that count as having an appointment. So GP, nurse, various different R's roles and stuff are in there as well. Care coordinator, interestingly, does count as an appointment. I think some people may have considered that doesn't. Important to recognize things like your practice manager, your reception teams, for example, unless they're considered care coordinators, wouldn't really count within that and stuff and things as well. So yeah, just being aware of the different types of appointments that are considered there.
Yeah, I mean, an observation for me here, Gandhi, about what is defined as an appointment is it's much more than a traditional appointment with a doctor or a nurse or a healthcare assistant, which might be what was kind of traditionally at the beginning of the data recorded as an appointment. So I think there's going to be a period of time where, as people get better at recording appointments to these definitions, we're going to see an increase in numbers of appointments delivered, which I think is probably expedient for everybody, but it may not represent a genuine increase in the amount of general practice being delivered. So I think that's just something that everybody just needs to be cautious about. If people are saying, oh, there's 1 million more appointments, well, it might be that we're counting 1 million more appointments, but it's not necessarily the case that has happened. So as the governments and the NHS, try and work out what is being effective at including appointments, they need to understand some of the deficiencies in this data and how it will have been recorded over time.
Yeah. And worth also mentioning about the fact that there probably are more additional roles that aren't counted on there that won't satisfy the requirements. So it says about other registered professionals, but I guess since then we've had things like GP assistants, trainee nurse associates, that kind of stuff that would probably still count, I would imagine, as an appointment, but aren't on that particular list. Worth noting from there.
From a little while ago, isn't it, when the R's list was shorter?
So let's get back to the types of appointments. So it mentions 3 particular things. So you've got care-related encounter. So this is basically something with a patient interaction of some sort. And we'll talk about the modalities of those in a second. Then talks about care-related activity. So this is not necessarily where you've had patient contact, but stuff around the patient. There'll be things like your results. There'll be things around, that kind of stuff.
Mm.
And then
which is interesting because in setting these categories and allowing us to record them on the rota, it does allow for them to be counted, in the future.
They don't count it. Yeah.
Well,
definitely.
They don't count as an appointment, but
Yeah.
at least the data is being recorded. So the activity, can be understood, which was a criticism of the GPAD data initially. We were saying, actually, what about all of these tasks that are done that are not necessarily captured? But I guess this is a way that
yes and no. So I think it comes down to the mechanics. So because it's counted through the appointment book, unless you are actively putting each of those interactions down on the appointment book, it won't necessarily count as an interaction. So it's sort of counted, but it's not counted, if that makes any sense.
No, it does. I guess what I mean is it's kind of there's a mechanism for valuing that work now.
Yeah.
People would have to record it in a different way. It would have to be recorded on the appointment ledger, which actually is a little bit impractical for a lot of the kind of ways tasks are set up, particularly in System 1, because you'd have to transcribe it across and book an appointment, which would be, quite cumbersome way of doing it. But at least there's the potential for it to be valued in the future, and clinical record systems manufacturers could change, how easy it is to slot these into lists on ledgers, for example. So I just thought that was interesting to point out. And then there's this third category of administration and practice staff activities. So these are sort of all of those interactions between staff that are required to just manage the practice. So it's sort of recognizing that is work as well, and has the potential for valuing that in the future, which I think is interesting and positive.
Is important. Then it mentions about for ACC08 about the types of appointment slots they expect you to use for the accounting for towards that. So there's the 4 main ones, which are general consultation, acute, unplanned clinical activity, walk-in, and clinical triage. And then there's the additional ones that also included within AC08 about the 2-week appointment. Let me just restart that back again. So there's the first part that sets out for the CAPE plan, which is the ones I've just mentioned. Then for the 2-week aspect of ACC08, there's the additional ones, which is general consultation acute, general consultation routine, unplanned clinical activity, clinical triage, walk-in home visit, care home visit, and care-related encounter that doesn't fit into another category, which is basically your catch-all mechanism and stuff. And they're kind of seeing that, where people need to allocate them. And I think they're trying to understand how that works better with those kind of ones. But typically, those are the slots that you should be using to allocate for your patients booked within 2 weeks. Important to differentiate that there is one subset of appointments for those for practices, one subset of those for PCN delivered workload, particularly the R's roles and stuff. And then as we come into in a second, the third setting, which is the enhanced access setting. Is that correct, Andy?
Yeah. So I think we're talking about appointment types, then we're talking about settings, and then the mode that encounter took place by. There's a nice annex and table at the end, which helps us understand the role of these different categories, essentially. So the setting. So in fact, we're getting towards the table here. So maybe it's worth
let's have a look at it, shall we?
Having a look at the table, essentially. So really what's important is the mode and then the location of the service, and then the setting to be. So if it's happening in, if it's a practice team, it's providing core hours, that it's saying actually when you're setting up your appointment ledger, you set the service to be used as general practice. Whereas if it's in core hours, but if it's our staff, then it's primary care network activity. So this table is there to help you understand how to set up your rotas.
And then it further differentiates for enhanced access, because I think they're keen to try and capture what considers an enhanced access or provision and stuff. So you've got the extended access provision categories in there, and then you've got the catch-all. The next part talks about mode, and this is probably the one that came in afresh back in April. So it talks about 6 different modes of consultation. So you've got face-to-face as a home visit, your face-to-face taking place within the surgery. You've got not an appointment, which is as it sounds.
Something else.
Telephone or audio consultation, video with audio consultation. So I guess you can't really, by their definition, have a video without audio. I don't know. Maybe it's possible. You could mime your consultation, play charades, and then written, which is your online consultations that many of us can consider and stuff and things. And then it talks through basically a step-by-step process of how you need to put these into the appointment slot, appointment books and stuff and things, which is quite nice. And then, as you can see, there's the link to the appointment definition article that myself and Andy just showed you. Yeah.
So, and then obviously there's links to support for putting this in place. And I think the new functionality here, I believe, is the modes. That's what it's saying here. The new functionality around the mode. So I think this just makes the data richer for NHS England to understand what's happening in primary care. Is that a good thing or a bad thing, Gandhi?
Which part?
In your opinion?
Yeah, which part?
Just the data. I mean, some people think, well, yes, people might be uncomfortable about this level of data going to NHS England. About what's happening in general practice. Is this overreach, or is it necessary for them to manage the contract as it is? Is it necessary for them to manage a future contract they might want to put in place where payments flow more differently? Do you think this heralds a future where payments might be linked to activity more closely rather than the broad concept of delivering on the needs of your population, as is currently what we're required to do in the GMS contract? I don't know. What do you think about providing all this data?
I don't think there's a problem with capturing the data. I think there's always been cynicism and concerns, whichever way you want to take it, in terms of how that data may be used in the future. I think right now, actually what it shows that general practice month on month is increasing its delivery of appointments. But like you said, there does need to be that conceptual discussion about what is considered an appointment. And does that mean we're getting more GP appointments? Maybe, maybe not. I think there are a couple of things that you need to be aware of when it comes to this data, and it's glaring outright holes in the data from my perspective. And I know this is something I've discussed in numerous times and stuff, but because the capture source is the appointment book in the clinical systems, they are not designed to easily capture appointments unless it's a pre-structured template. And this has real problems because it massively undercounts the amount of work that general practice does. Unless you live and work in general practice, you won't understand how challenging this can be. But simply just adding an appointment is not as simple as it sounds. It's a really cumbersome process you have to go through. So as a result of that, it doesn't often work. And particularly changing an appointment from one subset to another to count for the slot type is not simple. In fact, a lot of people probably won't even have the rights to do so because the system is designed to prevent you from doing that, because otherwise it messes up the rotors.
Yeah. So it's as simple as, well, this person was, they were booked a telephone appointment, but actually they felt a bit more unwell. They've actually turned up here at the time of their telephone appointment to have a face-to-face appointment because they felt that's what they needed. And actually we saw them and did it as a face-to-face appointment, but on the ledger that will have been set up as an appointment type as a telephone appointment in a telephone clinic. And actually it's difficult. Do you cancel that and then book them in again as a face-to-face? How do you handle that? So it's tricky. And what happens is that people probably don't record the data in the right way. They do the right thing by the patient, but they won't record that there was a more resource intensive encounter that happened, for example.
And the other big one is the concept of online consultation data. So the reality is, to put an appointment down for every single patient that you've done an online consultation with is exceptionally cumbersome work. I know some places where they actually will try and do that. So they put them onto the slots, they allocate it to the individual clinicians. They may have administrators whose sole job is to go back and add all these onto the appointment books to try and account for the data, taking them away from other roles within the practice. And the simple part is that a lot of that online consultation volume of capacity that's being done is not being accounted for, because the systems do not allow that to happen in a simplified way. Now, I know some of the online consultation providers have different views around this. Some feel that this is just not something they need to change, because actually the process of accounting for the data is incorrect and the process should change. Some of them have tried to come up with workarounds, potentially using things like robotic process automation and that kind of stuff to support it. But the reality is this part of the workload is not really well accounted for at all. And actually, it's a growing workload in general practice. So I think it means that the data is false. And NHS England absolutely are accountable for the fact that they're perpetuating false data for the public to be aware of, and us as practices as well.
Here, I agree entirely with you. In terms of solving that, I mean, the clinical record system providers and the providers of electronic consultations are placed well to solve that problem if they can work together effectively to make that happen. Although I'm sure it's not technically easy, because we're talking about two systems that were often operating in parallel in terms of electronic consultation systems on one program and traditional appointment ledger and clinical record systems on another. So that's where the difficulties are. And I guess if people aren't doing this in practice, you don't necessarily see where those difficulties lie. So yeah, I agree that it's
another example I think many practices probably aren't aware of. So for example, at the very least for system 1, I'm pretty sure it's the same with EMIS, home visits aren't counted for because they're not put onto the appointment book. So actually a lot of practices, when their data gets published, will probably say that they do no home visits at all, when actually they may be doing loads, but it's not accounted for. So that work, which is actually one of the most intensive and time expensive routes of consultations, not accounted for at all for a lot of places, because they're not actively they're not actively putting them back on the appointment book and stuff. So I think there's a lot to be said about the process doesn't quite fit the data. Obviously, this data is shared and used nationally by the media, by everyone. If the data's not right, do they need to stop?
Yeah, and might be worth just showing just an example of how the data is used and where you find it, really. So on NHS Digital's website, you can go on, or you can just search on Google, appointments in general practice, and give a month. And currently they produce a monthly report with highlights, and you sometimes recognize these figures in media, mainstream media articles, because they often kind of come along and have a look at this data and write a story around it, essentially. Yeah. And you can download more kind of regional data around it as well. It could just go down to by region, by I think the data does go down as far as individual GPs.
Practices. It does go down to individual practices as well. Yeah.
And if you're part of the system, you can register to access this data in a web portal, I think, as well, to have a look. I don't know if you've had a look at that side of things. You do need to log in, Gandhi. So that's that, really. So hopefully people can have a look at the new consolidated guidance. I think the new thing here is mode. I think there's clearly an intention to try and get this data as good as possible, notwithstanding the limitations that we've identified, which I'm sure NHS England are aware of and hopefully motivated to correct. And as I say, I wonder how this data is going to be used in the future, because that's always the concern people have around collecting data, isn't it? So, well, the current use that you want to collect my data for is fine, and I'm happy with that. But the thing about data is, once it's collected, or once you have the mechanisms to collect it, people may come along in the future and choose to do different things with it that weren't originally talked about. That's the classic problem people have with data collection and data sharing, by the government, don't they? So it will be interesting to see what comes along. And in some respects, I guess, these are provided under a contract, from NHS England by general practice. And, they might argue they've got a right to know how those funds are being used from a public interest perspective. But an interesting topic. Any final thoughts, Gandhi?
No, just do have a look at this. I think it's really important that we do try and capture the right data. And my last comment is going to be a massive plea to the system providers, to the online consultation providers, and to NHS England: sort out the accountancy process, because it's wrong. It needs to be better. Stop making it bump to be honest, for lack of better terms. And as ever, if you want more details, we will happily cover this. If you actually want us to go through a guide of what this should be looking like on your systems and stuff, do let us know in the comments down below. It'd be an interesting episode, I think, for us to do, Andy, maybe. But, you know, we can have a look at that process and stuff. And alternately, you can check out this episode coming up right here that probably gives you more data about the GPAD stuff as ever. And we will be here to enhance your primary care and learning. And we'll catch you in the next episode.